All right, well, welcome everybody to this conversation about COVID, governance, and society. I'm Ian Hurd, the director of the Weinberg College Center for International and Area Studies that's hosting this event. This is one in a series of events that we have in a project on global governance in the age of COVID. And I'm really happy that today we've got with us two researchers who've contributed a whole lot to our understanding of how COVID is shaping society and what we're learning about society through the lens of COVID. And their insight comes from really different research fields, but they add up together to helping us make sense of the world that we seem to be living in now. So welcome to Professors Beth Redbird and Helen Tilley. Professor Redbird is an assistant professor in the sociology department at Northwestern and a faculty fellow at the Institute for Policy Research, as well as at the Center for Native American and Indigenous Research, with a long history of scholarship on labor and workplace issues, on class and inequality, and much, much more. And Professor Tilley is associate professor of history at Northwestern with a special interest in global medical cultures and history, science and society, and especially on the dynamics of European colonialism in Africa, empire, science, and medicine, mixing all together. And she's directed in the past the program on science in human culture at Northwestern, and also co-led the program on global medical cultures and law. So thank you both for being here. I'm really happy to have you and for you taking the time to talk a little about your work. I guess I'm interested in what your work has helped us to understand about COVID and about our lives in COVID, and also in how the virus has shaped your own research work this year. So let me maybe start with the first, and then we can move on to the second, with Beth first, if that's all right with you. So you've been gathering a lot of data on how people think about or act about or understand the world. Can you give us a little introduction to what that's looked like for you?
Yeah, I participate in two large data collection efforts. The first is a nationwide longitudinal survey that's been running since the beginning of March to understand our focus is the interconnections that are exposed by the COVID world. So how people understand COVID, but also how they understand their relationships to their communities and to institutions and to one another, how they exchange knowledge and resources in the COVID world. And then the second form of data collection is I work with a symposium of people who are cleaning and processing large quantities of GPS data to understand how movement works in COVID era. So sometimes we do work on informing estimates of infections and suggestions for reopening plans, but sometimes I think the more interesting work is how COVID has changed who we meet and how we move through space, and how it's changed things like segregation and interaction through the last 9 months.
So that sounds like an opening of a topic rather than the end of a paragraph. So can you say a little more? So what have you got? What are you finding and how it's changing segregation, how people move and all that?
Well, I mean, in a lot of respects, of course, we know we're all more isolated than we once were, but we also get to pick kind of which interactions we prioritize in a world in which the number of interactions and everyday meetings that we've had has declined a lot. And so what we find is that segregation in who you meet and who you kind of cross paths with every day has increased in the COVID era. And so we're working to develop measures so that we can monitor that going forward and see how long it takes for life to kind of resume its normal pattern, if it ever does.
And is that the cell phone data is the stuff that came out this week in Nature, is that right?
Yeah, we had a paper released in Nature that looks at the impact of movement for infection rates by public place, and how that's played into some of the racial and economic inequality in infection by neighborhood. So, for instance, we find that 10% of public places account for about 80% of infections that occur in public places, and that the way in which low-income neighborhoods are built and the way in which people across income and race are able to change their mobility matters for infection. So people with lower incomes are less able to reduce their mobility. They're more likely to be classified as essential workers. They're more likely to have to keep going out in order to get things. They have less access to things like personal shopping. But also, low-income neighborhoods tend to have smaller public places. Grocery stores tend to be smaller. There tend to be fewer of them. And so what that means is that people have to shop, more people have to shop in the same store, which increases the number of people per square foot or the density of a place, but also it means that people spend more time in that place. And density plus increased time with a bunch of people in a small space is a perfect storm for the way COVID spreads. So we find a link between the way in which low-income neighborhoods tend to be built and racial inequalities and infections.
So does that seem to be then saying that the patterns are revealing the inequalities that were built into the system before, physically and socially built in, or I guess, and making new ones or exacerbating old ones?
Yeah, I mean, to some extent, we know that increased infections and increased mortality is the result of systemic problems in access to care and pre-existing comorbidities and things like that. But one of the things that our research points to, I think, is that there are other structural problems that have created these inequalities. I think the good news is that to some extent, we have some control over mobility more than we do over, say, a lifetime of difference in access to care, in that we can do certain things. In the same way we're constructing field hospitals when hospitals become too crowded, we can construct field grocery stores if we chose to, in places where there are food deserts or places where too few people are served by food establishments. We could create other larger places for people to access food. And so our recommendations are to do the kinds of things at neighborhood level that reduce density. So if you find a lot of people take public transportation, put on more buses so that there are fewer people per bus, right? If you find that there are too many people per grocery store, make some field food distribution places, these kinds of things. So while we know, for instance, from long streams of history that food deserts are a problem, in the COVID era, they're a deadly problem, but we can do solutions to them. We hopefully can create long-term solutions, but at least in the short term, we can make solutions that decrease the risk of infection.
Great. Helen, can I invite you to speak up, because this theme of kind of revealing the structural inequalities in global society and local society are familiar in your work as well.
Yeah, and I'm happy in a way that this is an intimate group, because I always notice in smaller seminars, it can be really helpful, especially with this medium, to invite people to pose their questions early on so that we have a sense of the kinds of things that brought people to this panel. I was in the UK when the pandemic began. I was on sabbatical in Cambridge, England, and joined social media for the first time in my life, which gives you a sense of how connected I am and am not. So I joined Twitter pretty much to be able to follow certain journalists and social critics in various African countries. So I follow some people in Nigeria, in Senegal, in Kenya, in Uganda, and I also followed the African Regional Office of the World Health Organization and a few other entities that were helping me track in real time things that were going on. And I noticed that, I mean, one of the things that's useful to know about me is I'm trained in African imperial history, but I also am a comparativist, and I teach a lot of global history. And the precept of certain approaches in global history is that nation states that become superpowers tend to distort in analysis and understanding of different parts of the world. And so I also study global governance and the way particularly countries like the United States punch above their weight in terms of influencing what is and isn't paid attention to, and the construction of strategic ignorance about different parts of the world. So as the pandemic goes on, you see kind of talking point blind spots. And in the United States, as you would expect, most of the attention is addressed to the United States and what's happening in the United States, but the pandemic began a lot earlier. And I actually began by looking at some of the English language sources coming out of China, because of course China has transnational translating services as part of, you could call it propaganda, but also as informational services. And one of the things that the Chinese government began doing very early was translating their diagnostic and treatment manuals. And those diagnostic and treatment manuals served a phenomenally important function for certain countries around the world to get a quick grasp of certain on-the-ground patterns in terms of infection rates and the course of the illness, and symptoms that weren't necessarily being reported by groups like the CDC, and even at times the World Health Organization. And it also helped me see some of the old contests around socialist medicine, preventive medicine, primary care, that were getting, I noticed in the treatment and diagnostic manuals that I started to look at coming out of the United States, that just, you know, the US was approaching it in a very decentralized, high tech, sometimes obfuscating way. The New Yorker ran a couple interviews with people who were doing the diagnostic and treatment manuals, and it was clear that some people were reading those coming out from other parts of the world, but many people weren't. And so it was actually in real time a way to examine how information does and doesn't flow, and life-saving information does and doesn't flow. And then as time went on, I started to gather more data about how the pandemic was spreading in African countries. And it might be useful to show a map that a consortium of people produced early in the pandemic, relatively early, but it's still captured in real time, some key developments. So a group of about 40 students, academics, NGO workers, governance, people in UN agencies came together, and I interviewed a couple of them to produce this map and actually figure out in real time the index cases as they were coming into specific countries. There's a lot of information on this, but one of the two really important points, by March 28th, 36 countries had closed their borders. And we also know a fair amount about air travel and traffic into African countries. So a considerable amount of the traffic was going into South Africa. As I mean, you know, the continent of Africa gets only about 4% of all air travel traffic anyway. So the sheer numbers of people going in and out was relatively low. And I'd be curious, I saw Wendy Griswold and Lorraine Denzel, I'm sorry, I'm mangling words, sign on. So if you have other information to provide, I'd be really curious about that. But following these maps and then looking at case by case, country by country, what people were, what governments were doing. There was a lot of full border closure, a lot of other travel restrictions, and then a scaling up of training, testing, tracing that is not very powerful compared to a rich country like the United States, but given the nature of pandemics and infectious disease control is actually quite effective. So the ability of African countries to flatten the curve happened both in a government level and a voluntary level, with lots of existing structures that went into action very quickly, both state-run and non-governmental, that drew on decades of experience around HIV and in other infectious disease control efforts around polio vaccination campaigns that just quickly switched gears into SARS coronavirus 2 control, and existing infrastructures around Ebola. So watching that all unfold helped me understand that there was a Pan-African response, and maybe if it allows me, yeah, this as a slide. one of the legacies of colonialism was a Pan-African infrastructure for various kinds of activities. So the African Regional Office of the WHO and the Mediterranean Office, which is based in Egypt, began to join forces very early on from the end of January. January 30th was the kind of start the clock time when the World Health Organization said it's an international emergency. And then the recent network of Africa's 5 Centers for Disease Control, which are regional hubs across the continent, went into action. And one of the things they did around capacity building was the on-the-ground ability to test for the coronavirus. So by mid-March, 43 countries went from having no testing capacity to having testing capacity. And as I mentioned, unofficial efforts also went into place, civic and mutual aid groups. And if you follow the musical output, I mean, lots of both pro-democracy groups and groups working in tandem actually with students in China did an array of songs that were, most of them were multilingual, advertising that this was a danger on the horizon, wash hands. Social distancing is a really difficult measure, but mask wearing and washing hands were 2 of the main things that people emphasized. And then the dozens of small scale kind of micro financial interventions around social welfare policies that many different countries put in place. Now, these are modest in terms of how they appear outside of the continent, but they still made a big difference. And so the thing that was really the puzzle, and I'll stop the screen share. As I watched all of this stuff happening, the puzzle became, you know, there must be something about Africa's climate, or now, of course, the argument is youthfulness. It's the most youthful, the population is the most youthful on the planet of all continents. And there are all kinds of genetic arguments that get trotted out, but often human agency and institutional agency get pushed to the margins. And certainly the continental level coordination has been largely ignored, even in big articles like the Financial Times ran a piece, the Boston Review has done a survey that are really touting some of the activities that have been done. Even those stories still ignore a lot of the active control measures that people were putting in place during the very time period that was the crucial time period, January 30th to about the end of March. And those kinds of activities continue. So as you know, Ian, I wrote a piece about this for the Journal of West African History, in which I explore not just these sorts of issues, but also some of the controversies around drug testing and drug trials that have popped up at different times during the pandemic, especially when European figures get given kind of the spotlight, as happened on April 1st when 2 French scientists were given the spotlight to talk about their research on BCG tuberculosis vaccines. And they said, well, you know, let's do this thought experiment and let's try vaccine testing across Africa because nobody's taking any measures and because infection rates will be very high. So it's a great experimental terrain, which of course produced a phenomenal backlash in many parts, many African countries, including the DRC, in which one of the head coordinators of the pandemic response actually managed to step into the controversy as a consequence, Muyembe, who has been working on Ebola. And he felt it was okay to do vaccine testing, but ultimately got enough pushback where they pulled back from doing something like that. So these are the kinds of issues I'm interested in, especially around blind spots in organizations, even like the World Bank, the International Monetary Fund, that continue to argue that the entire African continent is still phenomenally vulnerable to this pandemic, not in economic terms, which is something I would agree with. I do think people are vulnerable economically, but the argument keeps being that at any day now, we're going to see the pandemic erupt in African countries, and that's just not happened yet. So I'll stop there.
Thanks. And let me remind folks in the audience, you should feel free to put comments in chat if you like, or if you want to wave your hands and get our attention, we'll try to unmute you so you can speak up, so it can be more of a conversation. So feel free to do that. But Helen, knowing some of your previous work, I would imagine then that you weren't particularly surprised by finding that this idea about who has expertise to manage a problem like this is unevenly distributed across the media terrain. It would seem to fit right onto the theme that I've heard you talk about in other contexts.
It wasn't a surprise. And again, I would invite people with expertise of different parts of the world to share their own perspectives. And I saw Peter Carroll also signed on, and we've had an exchange about some of the East Asian responses. I can't claim any clairvoyance. I was probably just as concerned about what would happen in African countries as anyone else, especially as I watched the pandemic in Italy and move steadily towards the UK, since that's where I was living. But what I also began to notice was, I mean, a couple things, and I use I use a series of pandemic precepts with my students, and Bruce Aylward at the World Health Organization at the beginning of the pandemic said, if you've seen one pandemic, you've seen one pandemic. And the point is that there are ecological, epidemiological, and political economy contexts for any single pandemic, and those contingencies matter a great deal. And the point of origin of the pandemic matters, that it was East Asian. The relative incubation period matters, because that has actually made, I think, wealthier countries that are less equipped to deal with infectious diseases far more vulnerable. Contact tracing is not something that, it's something that the US has taught and trained people in, but it is not something that many parts of the United States have practiced. And in other parts of the world, there's a lot of practice. And the original SARS pandemic of 2002 to 2004 gave East Asian and Southeast Asian countries, and even Canada, an acute trial run. I mean, one of the things about that first SARS outbreak that was different was that there were no asymptomatic carriers, and that it had a shorter incubation period. And that very difference meant that it was easier to control. So actually, this pandemic is a lot harder to control because it's so diffuse. It's not an Ebola. Ebola is something that the US health infrastructure is well equipped to deal with and to control. The cases will not run amok, but a coronavirus of this infectivity and range of symptoms, where 1 to 5% of people could die, depending on vulnerabilities, that actually is a particular pandemic that has been more dangerous in wealthier countries because of the lack of experience. And that's something, who would have known? I was learning in real time about the nature of the infectious agent with everyone else, and we're still learning those kinds of things.
So, Beth, I wonder how this works for you. So how do you feel that the stuff that you've learned from studying COVID patterns relates to the things you were researching and learning before?
I did a big pivot come COVID, in part because I had the infrastructure in place to launch a national survey very quickly. But in some respects, I think that the interesting things about COVID in the US are very much related to the way COVID has led us to change our understanding of the interconnectedness of society. And I don't know to what extent that's a permanent change or not, but I mean, our data suggests that we see things slightly differently. So for instance, the idea that we see grocery store workers as essential workers and that we understand that people in a long supply chain, from truck drivers to meat packing, is somehow vital to our well-being is kind of this new switch, right? And so wherein before we used to study these kind of ideas of what it meant to have class inequalities and solidarity in society, we didn't see necessarily ourselves as quite as interconnected as we do today, which is interesting because we also see ourselves as we're more isolated today, right? And so while, for instance, we see more interconnectedness, we all feel more lonely. And in times of disaster and national emergency, what we often see is that we pull together as a people and we engage in increased solidarity. And in the pandemic, we haven't seen that. We've seen a declining rate of solidarity. Now, there have been some exemptions to that, some exceptions. For instance, people of color who lived in largely non-white communities experienced an increase of solidarity late in the summer around the protests. But in general, we've seen this kind of like shredding of solidarity bonds. We're less likely to feel that our neighbor cares about us. We're less likely to feel that we should take care of one another. We're less likely to feel like the people around us are doing things that make our society better, which, I mean, this is just since March. This isn't since the beginning of political polarization or anything. And so those shreddings of those bonds, I think, matter for the ways in which we take in information and the ways in which we regard expertise and the way in which we care about public policy and health policy matters.
So you've been doing the national survey over time now, I gather, for a while, right? So,
yes, since March 11th.
So you see social bonds going down. What else is changing over time and how people represent this?
Faith in institutions has drastically declined, which is perhaps not that surprising. We're experiencing a period of large social disruption. We wouldn't be in a period of disruption if our institutions hadn't failed us quite so spectacularly. So it's perhaps not surprising that we have lost some faith in them, though not just pandemic-related institutions, and that's not just healthcare and the economy that our faith is shaken in. Our faith is shaken in infrastructure, and our faith is shaken in the military, and it's shaken in a whole bunch of other institutions that we don't think is necessarily directly related to the pandemic. We've also changed the way we take in information and process information. So for instance, we've seen an increase in the amount of information or the diversity of information that people take in. So in the United States, we tend to have a preferred media basket of consumption, right? We prefer our few sources of media and we don't tend to differentiate from those. But since the pandemic, we've seen an increase in the amount of diversity across people's information consumption baskets. So this is particularly true for people who were consuming conservative media sources. I think we see some evidence to suggest that they were aware that they were perhaps not getting the best sources of information, and so they diversified where they were getting information from early in the pandemic. Early in the pandemic, we increased the amount of information we took in, though that has since gone away. We're all, I think, information exhausted. So we see these kind of broad social changes. What those changes have for consequences of long-term impacts in the United States, or how they've impacted the ways in which people have taken in the kind of information that Helen is talking about, or how they evaluate expertise, or how they adhere to certain things, I think is an open research question that we have yet to really delve into.
Yeah, one of the things. Go ahead to Helen. Yeah.
Beth, because it's really interesting listening, and I'd love to hear you say a little bit more about the methods you use in terms of getting an aggregate picture. And I was struck listening to you that you use the word we to describe not just your research team, but we, as I'm assuming you mean Americans or people in the US. And I wasn't sure if I was hearing you right, but I'd love to hear how robust you feel the results are. And I wonder, because I study the US from the outside of the US in a sense, the US is a geopolitical actor. And one of the points I make to my students is that, and I use the Cornell University study, which I could probably screen share for everybody, the well, I'll see if I can do it quickly. The Cornell University study analyzed English language texts and found that Trump was the largest driver of misinformation. And then if you do the analysis of the state of federal obstruction of a response, the obstruction was just as active. So there's been misinformation, disinformation, and increasing authoritarian rhetoric, if not always backed up by practice. So do you try to capture those specifics when you're talking to people, or you just sort of do a snapshot of, this is not the context, your individual social position is the context? Like, how do you deal with context and what's going on for people?
Yeah, it's a good question. So we're doing a survey, and so our ability to delve in depth is highly limited. But we have 8,000 respondents it's a nationally representative survey with an oversample of individuals over the age of 55. And so what that means is we have people from across the country. We even have people in territories. And what we have from them is data on their attitudes, beliefs, and behaviors. And then we also have information on where they live and have lived if they've moved throughout the pandemic. And so what we can do, and what we do in a lot of instances, is we look at how their response differs by individual level characteristics, but also how it's embedded in a community, right? And how that community is embedded in a state, and how that state is then embedded in a national context that's changed over the course of time. And by knowing that about the respondents and with how large a sample we have, we're able to do those contextual analysis so that we can see, for instance, to what extent the things that are going on the local level impact how you understand national discourse or something like that. So we do know, for instance, that people have lost faith in institutions, but that it's national institutions that have suffered the most loss of trust, and that local institutions have fared better. Mm-hmm. But there's a lot of variation in how well local institutions have fared, in that there are some places, specifically states, where there have been no public health policies designed at, say, mask wearing or capping occupancy or anything like that, where state institutions have fared very badly. People don't trust them, they don't listen to them. And the flip side of that is, in other states, for example, New York is a great example, institutions have fared really, really well. And people have continued to find them to be really trustworthy and robust. And so, yeah, when I say we, I often mean kind of as a national summary that disguises a lot of local variation that we find that is highly dependent on your specific community and how it's faring and how it's behaving and how your neighbors are acting.
And that conversation goes back and forth, interestingly, around your theme, Beth, of individual and social, in a sense, because defining who the we is so interestingly important, whether, the moments when it's a local we and when it's not. One of the things I found really interesting in reading your data was the way that it seemed to document how people have been taught who is especially vulnerable. So, right, the old people in collective living, homeless, prisoners, who's especially vulnerable. But that's different than who is likely to spread it. And the vulnerability is kind of the individual characteristic, an old person who is vulnerable personally. But the social danger comes from the people who are likely to spread it, and that's a different population. And I can see how those two different ideas might be hard for people to keep in mind, and that comes out in your data. And it matters a lot for designing responses like a vaccine program, where you would presumably want to be alert to whether you're targeting first the people who are individually vulnerable or the people who are causing the most social disruption by being at the center of super spreader events.
Mm-hmm. Yeah, I think that's a really good point. I think one of the keys to understanding about the US in terms of kind of policy looking forward and how experts can get us kind of on a new track come January, Lord willing, and the creek don't rise. I think that it's important to note that there is a lot of local heterogeneity in the United States, that the federalized response to the pandemic, which kind of tossed it to states, which then many states sort of tossed it to local mayors, has resulted in a lot of heterogeneity in response and therefore infection, but also in trust and behavior and habit and these kinds of things that moving forward, if we wish to generate a nationalized, not nationalized, but a nationally consistent response to the pandemic, if the new administration wants a national mask recommendation or anything like that, they're gonna face perhaps a location that's far more heterogeneous in terms of how we feel and how we've been behaving for the last 8 months and what habits we've developed than they might be expecting.
Yeah, and I just chime in here and say, I mean, one of the things I've also been doing, as probably all of us have, of reading the fabulous journalistic coverage of some of the topics. So Ed Young did the article around America's patchwork pandemic. And I found the idea of patchwork quite useful, even in terms of a legal term and jurisdictions, that everywhere the pandemic has unfolded in a patchwork style and in different densities and concentrations and places. So I use, again, I mean, I'm using some of the teaching tools because I find it useful to share these because they can be so helpful in making sense of key concepts to take away. I'll see if I can get this. Because there's so many different kinds of points that we all might want to walk away with lessons. You know, so this is just again, an economist graphic, but it helps. They did the mapping of fatalities by the county or district in which they occurred. And actually the tracking, if you go to the website, you can actually click on the different peaks and you get the data points. But I use this partly to talk about herd immunity, and especially Sweden's trial run with herd immunity compared to Finland and Norway, and what that meant, both in fatality rates and in caseload, and also in economic impact, because as most people probably know, Sweden didn't fare much better than Finland or Norway in terms of staying open. Its economy actually took the same kind of hit because the idea that nation states and the borders matter a great deal in a fairly transnational economy just doesn't work in quite the same way. So even if they wanted to pursue herd immunity and keep their economy open, it doesn't actually have the effect that people wanted. And you can see for the US, I have a couple different, oh, I won't. See if I can go up, you know, in terms of US densities, there are, since over time, you know, densities of fatalities that have accrued quickly in the Northeast, but fairly slowly in other parts. And again, this is from the Financial Times. They've done some great graphics. So you can see the aggregate up to November 10th. About where fatalities have happened. And there's a real interest, and this dovetails with your work, Beth, because I suspect that in places where the pandemic has moved more slowly, but still led to as many fatality rates, I suspect the perception of it being an incredible danger is much lower. And you can see, there's a wonderful graphic that's a time lapse that I also use, fatalities since July by state. And this is actually per capita, so deaths per million. And this is a time lapse that you can actually go onto the website and it'll show you over time how the states keep going back and forth. And this is state level aggregate data, but it surprises a lot of students to realize, it doesn't surprise many people following the pandemic, but it surprises students to realize just how bad the pandemic has been in more Republican controlled states. and still how little that has mattered in terms of the election, at least so far in terms of the information. But again, that may be something you know more about, and how the pandemic affected election outcomes.
No idea. We do have, I say we in part because we have a team of about 16 social scientists who work on the survey. And there are a collection of political scientists who are hoping to keep running it through 2022 to understand the impact of the pandemic, not just on trust, but on how long it takes trust to rebound and how long it takes, like whether or not trust can rebound. Is it a new administration that helps rebound trust, or do they have to do something for trust to rebound, or do we never trust again, at least till 2022 in the midterms? In terms of explaining what happened last week, I have no idea. The first person who comes up with that should give a giant talk to all of us, because I have no idea how to explain. I mean, we do know, and in line with some of your information about the sources of disinformation and stuff, we do know, for instance, that trust in specifically Trump and the White House is the biggest driver of your public health behaviors in terms of trust, right? Like if you trust Trump and the information coming out of the White House, you are the least likely group to wear a mask in public and to social distance, right? Like it irregardless of your political party, like if you are a Republican who trusts Trump, you don't social distance. If you are a Republican who doesn't trust Trump, you do. If you're a Democrat who doesn't trust Trump, you social distance. If you're a Democrat who trusts Trump, you don't exist. They don't happen in our survey. So that source of misinformation is very clearly a huge driver of public health behavior. How it drove political behavior, though, I have no idea. This is a very good question. We're actually in field through next week, so we will have people's vote preference. We're not the National Election Survey, so we're not necessarily equipped to do a good job to catch people who say they voted when they really didn't, and the social desirability aspect of that. But we're in field, so hopefully soon we'll be able to answer a few of those questions.
And are you big enough to get kind of the regional differences that Helen was pointing out? How does that look?
We are big enough to do regional differences. We are also big enough to do contextual analysis, but we're not big enough to do is by state. So we can't break it out and say how California differs from New York. Well, we can with California and New York because there are a lot, but we can't tell how North Dakota and South Dakota differ from one another. But we can tell, like, you can line up big events and say, how does the first 100 deaths impact a location? Or how does the speed of a pandemic in a particular area, to Helen's question, how does the number of deaths versus how quickly the pandemic hit and what wave you've been most susceptible to matter? And we can do that at both the state level and the local level. So we can look at how many deaths are in your zip code and has that mattered? I haven't personally done that work, so I don't have the answer to that, but we are big enough to know it. And I will also say we're sharing our data with other, particularly Northwestern researchers, but researchers throughout the country. So if you're interested in any of this data, I don't know, send me an email or something, and we can talk about what we can get you access to.
Cool. What have you found most surprising, or is there something that contradicted your preconceptions?
I don't know that I had preconceptions. Helen mentioned Ed Young's work in the pandemic and the patchwork pandemic, and we contributed some data to that article in part because when he and I were talking, that had been one of the most surprising things to me. Is while we knew that policy response differed drastically by location, we kind of had been making the assumption that because media coverage, so much media coverage is local and so much media, I mean, at the time, particularly, Trump was still doing his daily briefings and those were getting covered rather extensively. We had made the assumption that while response had been highly local, information was rather national. And I think one of the things that most surprised us is that it turned out while information was national, the ways in which information impacted things like trust and solidarity and things turned out to be highly local. And so I think his observation that the patchwork pandemic impacted the way people not only behave in terms of public health behaviors, but also how they saw the pandemic and how they feel about the pandemic was really interesting observation.
Yeah, that's kind of interesting because, I mean, when the patchwork makes a lot of sense, but the local is a policy question as well as a kind of built environment and kind of socioeconomic set of issues. It seems to me like if there is any intellectual justification coming out of the federal government for its total lack of, you know, attention to stuff, it's that these are better done locally because local is different. So this is sort of a roundabout way to wonder for both of you what you think the space is for federal response, for coordinated national decision making, if we accept the kind of patchwork idea.
I mean, I will say that I do think that both sections of my work point to this. The movement data also points to the idea that the way people are moving through space is to some extent based on their built infrastructure, which is an incredibly local concept, right? How a neighborhood is built and designed differs. I mean, Chicago is just not Houston. And as you wander through two neighborhoods in the two cities, you can definitely tell them apart because they are not the same. And so because of that, I think what we see, and because people feel so differently about the pandemic and the habits they've built and the understanding of their role in the pandemic, both in terms of vulnerability and how much of a threat they are to their neighbors, differs so much locally, I think that any national response is going to face a challenge of that some public health behaviors are perhaps best directed at the local level, but also that people are behaving so differently at the local level that large policy prescriptions face a large hurdle in terms of just getting everybody kind of on the same page. Whether or not the solution to that is then to fund or to fuel money through to the local level, I don't know. But I mean, Helen may be better equipped to address that because she studies the interconnection of governments all the time, and I don't.
Yeah, I mean, one of the things that I think is easy for a country as big as the United States to obscure at the national level is its power and the possibilities of what it can do. And there, again, living in the UK, it was interesting because many social democracies have a much more robust social safety net. So even if fatality rates and caseloads are high across Europe, and they are quite high, and the European countries are experiencing a second wave, in the UK, people who were furloughed, people who had to stop working, got 80% of their income subsidized immediately. And the National Health Service, for all of its limits during the pandemic, still functioned and still did the kind of vaccination programs and well baby checks. And I mean, and where I was, you know, you could go to your GP still for basic needs. You just couldn't get a COVID test. You could only get a COVID test in the hospital. I think the US government has an epidemiological project that it could do much more effectively, which is flexible coordination around infrastructure, testing, tracing, and controlling. And we have seen the opposite of that. People in the United States have experienced and lived through active obstruction. And I do actually have a slide where I do the timeline of the first briefing in January, on January 3rd. The first serious briefing on January 23rd because Wuhan shut down. I mean, the United States has the most sophisticated information about epidemiology globally of any country in the world, and it sat on it, and it deliberately concealed it, and it stopped mayors right around February 2nd, February 6th. It stopped 5 mayors, Chicago, New York, LA, Dallas, with major hubs, transportation hubs, from actually acting on the information. So that kind of obstruction signals a massive failure of response. And that's what shocked me because, you know, I called it epidemiological malfeasance privately to friends. I did actually not expect the Trump administration to abrogate such responsibility and to shut down possibilities and to start creating a free-for-all to the point where Republican governors were actually becoming whistleblowers on the Trump administration as people tried to get PPE equipment into their states. So the scaling up of coordination and flexible response as a pandemic moves, and it does move. I think if there is a transition of power in January, note the if, if there is a transition of power, I actually think that there will be a possibility for epidemiological control, but the economic and social safety net is far more important for the medium and long term. And that's where possibilities also have opened up around basic income, around issues of rent and eviction, around debt relief. And again, the United States at a federal level has a lot of flexibility, and there are many possibilities to alleviate suffering and mitigate harm that may or may not be on the table in the first few months of a new administration that really were shut down. And I would argue, and I'm not an economic historian or an economist, but I would argue that there has been a massive transfer of wealth in the modest 1% already during the pandemic because of the federal response and the way it was structured to benefit the wealthy. So the $1,200 check that still hasn't gotten to a lot of African-American communities, that $1,200 was a drop in the bucket for what the United States can do at the federal level. And that part of it would be very interesting to see. And the same goes, by the way, for debt relief at the global level. I mean, there could be very interesting debt relief for African countries in Latin America. And there are reasons why that isn't going to happen. The same issue around sharing the genome of the coronavirus. It took only 2 weeks to sort out from the end of December to January 12th, the genome of the coronavirus 2, SARS coronavirus 2. It took 4 months to sort out the SARS original 2002 SARS epidemic. That 2 months, that 2 weeks allowed a test to be developed by mid-January by a German company that was then sent to the World Health Organization that the WHO used for its model testing. The United States, because it operates as its own fiefdom, didn't use that test and did its own CDC test, which was a failed test. A sheer accident, because the CDC used to have terrific capacity to develop some kinds of influenza testing and the capacity to scale it up. So that was another contingency of the failed response. But the fact that those things happened freely, were freely shared, literally non-monetarily shared in January, was enormous for vaccine development. And now we're experiencing this question in the World Trade Organization about whether there will be a waiver of patents around the vaccine, which is in some ways an indication of the failure of global systems to understand that human need might come first before Pfizer, which is the wealthiest pharmaceutical company on the planet, makes another killing.
And I think Helen raises some really interesting points about, unfortunately, we haven't seen increased preferences in the United States for things like universal sick leave or anything like that. And so I'm a little more pessimistic about the likelihood that we'll see big programmatic changes in the US. I will say, though, that all the processes that I talk about in terms of lost trust in American institutions didn't just occur in America. There's lost trust in American institutions worldwide, both as a response to Trump and the administration, but also in terms of pandemic response. And you put those things in the context of a history of imperialism globally, and you see the interactions between kind of I mean, Helen talked about the testing of a TB vaccine in Africa. I mean, there's a long history of imperialized medicine too. And so when you couple those things together, I think, well, I'm an expert in the ways in which the pandemic has impacted what we understand about American institutions here. Globally, there's a need to understand that too. And I'm also not optimistic there.
Yeah, to be clear, I was talking about what's possible, not necessarily what will happen. But I mean, the realm of possibility is always bigger when it's a powerful entity. And sometimes what's interesting is how the windows of those possibilities get so narrowed in people's minds that it seems impossible. But I agree. And the imperial history of biomedicine is something I teach actively in different parts of the world and have studied actively. And those concerns are real, though in some places, and I think in African history that you often see this, there is distrust, and there is also a desire for medical self-determination. That's kind of a phrase I use, where countries actually, there's a kind of anti-state, pro-state dynamic where people want to control the infrastructure for medical care on their own terms and not have a group like the Gates Foundation constantly dictate. The Gates Foundation gives away approximately the same amount of money every year that is the budget of the World Health Organization, about $6 billion. And so they want medical self-determination, and there is dubiousness about certain forms of medicine across a lot of axes if it seems to come from the outside. And that could be a humanitarian organization, that could be an infectious disease control campaign, as we've seen in the Democratic Republic of Congo with Ebola, and Doctors Without Borders, some suspicion about some of their activities. But if there are kind of homegrown primary care medical institutions, there tends to be a lot more trust and a lot more use. I mean, a kind of clamoring for those institutions. And a desire to control which experts actually come to the table too. So this goes into also the infrastructure development that's gone on in a lot of African countries over the last 40 years. And it's been really uneven in different places of building up medical education and licensing protocols for public health infrastructure that helps to explain why the testing capacity got off the ground that much more quickly. It wasn't really there at the beginning of the pandemic, but it did build fairly effectively over time. But trust and social trust is a huge issue across the board in terms of anytime an outsider or a set of outsiders come in to control things. And we would see that, you even see that now with the kind of foreboding of, is there going to be a massive lockdown in the United States? That I've already seen on Twitter, that kind of pushback of, Lord, no, that will take away all of our civil liberties, that kind of response. Again, that's something you're probably examining more closely.
Yeah, this is maybe a good moment to introduce the next event in this series. It's a conversation with Lindsay McGoey, a sociologist who has paid a lot of attention to the Gates Foundation and similar philanthropies and their role as a kind of privatized version of public authority on health and other issues. And she's also involved in the WTO free vaccines campaign that Helen just mentioned. So that will be a conversation like this one on Thursday, December 3rd, and it'll mark the next installment of the series on global governance in the age of COVID. I'm going to wrap up here because we've reached our allotted 60 minutes. We have to put in more quarters into the Zoom machine if we want to go for longer. So thanks to Helen and to Beth for talking about all this stuff. So interesting, so many big themes. Thank you both.
Thanks. I actually didn't realize we ended, but there was a question from the audience about GPS and movement data for Beth that I don't know, Beth, if we, or Ian, if we have a second to answer that. I thought we went till 2:30.
Oh, I see. Yeah, I think
Sorry.
that's right. Yeah, it was a question to Beth to talk more about the GPS data project, which the question came in after, I think, Beth, you had already covered some of that. So, but if you wanted to expand any more, you're certainly...
Well, I will just say, I mean, this is, I think the gentleman who asked the question is a student in our department, and I'll talk to him privately afterwards and see if he wants to be involved. We like graduate student involvement. But that being said, it's another source of data that we're trying really hard to make available to people. And it contains information on movement, not just through place, but movement to specific locations. So we know, for instance, if people are at restaurants or at places of worship or a whole host of other fitness centers, things like that. So it's a really, really, really large and very cumbersome and hugely difficult data set to work with, but it's there, and we help to some extent for people who are interested in using.
Great. Well, thanks a lot. Thanks for taking the time.
Thank you.
Appreciate it. Thanks, everybody. We'll see you again soon.
Ciao.
Bye.